Very much, thank you for having me. So I'm an MB PhD student based at the Department of Medicine at Addenbrooke's Hospital, and I spend my time thinking about cardiovascular risk prediction, and today I'd like to talk to you about stroke. So every 2 seconds someone in the world is going to have a stroke, and every 5 seconds someone dies from a stroke. So in the UK society alone, this costs about £26 billion each year. But what is it? So a stroke can be considered as a brain attack. It's where the blood supply to part of the brain gets disrupted, the brain cells are deprived of oxygen, and then they start to die. 85% of the time, this is due to a blood clot, so that's an ischemic stroke. The remainder is a hemorrhagic stroke, that's when it's caused by a bleed. A transient ischemic attack is a mini stroke, so that's when the symptoms resolve within less than 24 hours. However, there's currently no asymptomatic screening program for stroke, so that means we don't screen the general population for those at risk of stroke, and that's because the overall incidence is relatively low. So first-time stroke in the UK is about 230 per 100,000 people per year, and that's even lower in terms of a TIA. However, once a person's had a stroke or a TIA, they have a really high risk of having another event. So about half of all strokes that occur after a TIA will happen within the first 24 hours. 1 in 12 people will have a stroke following a TIA within the first week, and 1 in 4 people who've had a stroke will have another stroke within the next 5 years. So the unmet clinical need is a widespread clinical prediction model for recurrent stroke. Now, carotid artery disease accounts for 20% of all ischemic strokes. That refers to atherosclerotic plaque building up within the neck vessels. And in recent years, we've recognized that atherosclerosis is a systemic inflammatory condition. So overall, that makes a person a vulnerable patient. They're more at risk of having an event. With the rise of functional imaging, we've actually been able to pinpoint the vulnerable plaque. So this is the plaque that actually led to the stroke or the heart attack. And there seem to be differences. So if you look at the image, there seems to be increased metabolic activity related to what is known as the culprit plaque, the one that was responsible for the event. We also know there are other characteristics associated with this vulnerable plaque. These include having a large lipid core, neovascularization, so that's the formation of new vessels, which also gives it risk of having intraplaque hemorrhage and microcalcifications. And using MRI imaging, that's really effective at picking up these components to do with the vulnerable plaque. But thinking about clinical practice, in terms of arterial imaging, the equipment is not as widely available, and it's much longer in terms of imaging time compared to CT. Now, if someone has a stroke, it's already part of routine clinical care to actually have a CT scan, and the scans can be completed within minutes. The downside is you can't really look at the individual components of the plaque. So that's where textural analysis comes in. We'll try to mine the information within the CT image to see if we can overcome this disadvantage. So here are a few examples of contrast-enhanced CT scans, and these are axial slices through the carotid artery. Some of these plaques were responsible for a stroke or a TIA, some of them weren't. And it's not always easy to tell the difference qualitatively. So the one at the bottom, which is culprit, that looks relatively innocent. It's got quite a patent lumen. Actually, that led to an event. Whereas the other two, they look quite similar. They have quite a lot of areas where it's bright white, so that indicates macrocalcification, and yet they have two completely different statuses. In terms of textural analysis, this has been gaining ground in oncology. It's been used to study heterogeneity in tumors because tumor heterogeneity is more associated with malignancy. And these texture parameters that have been derived from the images have been found to correlate with biological and pathological processes such as hypoxia and angiogenesis. They even correlate with genetic variation. So in a way, you are studying heterogeneity at multiple different levels. And we thought that actually this might translate well into cardiology because you still get the similar pathophysiological processes such as hypoxia and angiogenesis occurring in atherosclerosis. So what we did in Cambridge, we've curated a data set of 80 patients. They've had CT scans of their carotids. 46 of these patients are symptomatic. That means they had a stroke or a TIA. 34 of them are asymptomatic. They didn't have an event. After accounting for those who've had prior carotid surgery or image quality, that leaves us with 41 culprit carotids, so ones that caused the event, 41 non-culprit carotids, and so that means we can do analysis for the vulnerable plaque. And we also have 65 non-culprit carotids, so actually we can do between patient analysis to do vulnerable patient analysis as well. So using Textural, which is a commercial research software, we analysed a single slice through the carotid artery. We drew a region of interest around the vessel wall, and we extracted texture parameters from the histogram of the grey level intensity values of the CT image. And what we found is that when you compare the most diseased slice of the culprit artery with the carotid bifurcation of the non-culprit artery, all of the unfiltered texture parameters are significantly different. Now, this confirms something we already know. We know that stenosis in the carotid artery is an important predictor for stroke. And actually, those who've had a stroke or a TIA, they will have an ultrasound scan of their carotid vessels. And if the stenosis is more than 70%, they will go on to have surgical intervention. Thing is, not everyone with a very stenotic carotid artery is going to have an event. And also, what happens to everyone else who has less than 70% stenosis? That doesn't tell you the whole story. So even when you compare just the carotid bifurcation of the culprit artery with the carotid bifurcation of the non-culprit artery, there still seems to be subtle differences that we've not really been aware of before. And there is a lot more work to be done. So we are thinking of doing multi-slice analysis, because obviously the plaque isn't confined to a single slice. It is throughout the entire carotid artery. So we'd like to look at the textural parameters that you can extract from a 3D volume. We'd then like to use a supervised machine learning approach for classification of the culprit and the non-culprit artery. And then we require further biological validation. There is some preliminary work that suggests that the characteristics we are picking up is correlated with processes such as angiogenesis in the carotid artery. And the end goal is a prospective multi-center trial where we use these texture parameters as clinical endpoints. But there is huge potential in medicine and industry. This could be a non-invasive biomarker for the prediction of the vulnerable plaque. It's very easy to integrate into the imaging workflow because all of the stroke patients will already have a CT scan. There's no additional radiation that needs to be added. It's relatively cost effective, and what you're hoping for is, well, if someone's had a stroke or a TIA, they've had their CT scan, we have a look at the texture, this can help us decide, is this a high-risk plaque that needs surgical removal, or is it stable? So we just intensify the medical therapy. And finally, I'd like to thank everyone at CMIH, the Department of Medicine, School of Clinical Medicine, those at Textural, and my funders, and to you for listening.
Questions?
Yeah, that was a really great talk.
Thank you.
Educate me. How do you place your regions of interest when you're doing this analysis? Do you go along the length of the vessel where you can see it, or is it limited to a 2D slice? And if so, how do you control
Yeah.
consistency across your readers?
Yeah, so we go through the axial slices, so it is just 2D. And in terms of the carotid bifurcation, we, I think variability between observers is quite a big thing. So what we have done is inter-observer variability studies, and it's quite high anyway. So in terms of the carotid bifurcation, it's relatively easy to identify. In terms of the most stenotic, which is what we use for most diseased, you can use multiplanar reformatting to find out where the most stenotic slice is.
I'm sorry, if you just indulge me for a second longer. If you take a healthy carotid and you look at different slice positions along its length, what do you think, or do you know the variation in the texture parameters is through that vessel? It should be very similar.
Yeah. So that's, I haven't done the analysis yet. So the next analysis will be actually comparing a healthy subject, their arteries, with the non-culprit artery from the symptomatic patient. So even though that non-culprit artery didn't lead to an event, we think that the person who had an event will still have differences compared to the healthy patient, but we haven't looked at it yet. Yeah.
You showed some p-values for the difference in skewness and kurtosis.
Yes.
Do you know how they were calculated?
Yeah, so if it was normally distributed, we used the paired t-test, and if it was not normally distributed, we would use the Wilcoxon signed ranked.
So for the skewness in kurtosis, normal. If it is normally distributed, it doesn't have a skewness in kurtosis, or
as in the mean values out of everybody. So it's not just, so it's the mean, so it's comparing the skewness values for the entire sample. So it's not, so if you're comparing between the two data sets, then it would be the overall data. So it wouldn't be the skewness of that individual.
It may not be clear that the skewness is actually a texture parameter.
Oh, right, I see.
Population parameter.
Okay, so yeah, so that the skewness we're talking about is from the image, but when we compare it between the two data sets, it's I don't know how to explain.
Actually, I'm Mike Haywell now, so I'm being involved in TechSide. The skewness parameter is a texture parameter that's extracted from the image.
so it's not the statistical skewness.
No.
Oh, okay, yeah,
Yeah.
that must be the confusion.
Any more questions? I just have one. Are you guys collaborating with a Swedish company that is using microwave for stroke as well? Are you part of that same division? I saw some advertising. No.
No.
Thank you very much.
Thank you.